Okay, so this chapter is kind of summing up everything that we've been trying to prepare for the last two terms. I've talked about patient preparation, lab work, machines in order, species specifications, breed specifications, and your understanding of the last two terms of material is trying to prevent anesthetic problems and emergencies, because I said on day one, and this isn't meant to scare anybody, but any anesthetic procedure can result in death. Unfortunately, that is why anytime an animal goes under anesthesia, they sign a CPR order, they tell us their wishes. And so the goal is we try to look at every possible problem that can occur, and then you work backwards. I used to tell people, and they sometimes look at me weird, and I say, I look at every case and I think, how can I kill this patient? And that's not my goal. My goal is, if I look at the potential problems a case gives me, and then I work backwards and go, how am I going to prevent that? But I already go in my head saying the type of surgery is risky. The patient is risky. The drug I'm using has bad side effects. The length of the procedure. And so then I go, well, what can I do to make this better? What can I do to prevent these problems? So what we're going to do is we're going to identify, this PowerPoint is twofold. It goes into high risk cases, or it goes into categories of patients and why do they give us problems? And then what can we do? And then what are the potential problems we fit? So there's a fair amount of monitoring that you're going to have to pull on in this lecture. And I know you guys are doing it right now in surgical nursing because Zuber told me. So hopefully the fact that you're talking about monitoring, we talked about that term one. And remember, was it 2 weeks ago, I sent you a monitoring sheet, like a handout that has normals. So all of that, you need to start painting a picture, and you need to think defensively. When you do anesthesia, you have to think analytically and you have to think defensively. And again, I always say being bored during anesthesia is actually a good thing. So let's break down some categories. So when we first get into anesthetic problems, they usually break into one of these four categories. Either, obviously we're human and we make mistakes. So was it human error? Was there an equipment failure? Are there any adverse effects of the agents that you're being used, or adverse effects of the procedure? And then, did the patient have any risk coming into the procedure, like a brachycephalic? They're automatically on my increased risk category right when they walk in the door, and I don't care if they're 6 months old or 15 years old. If they're brachycephalic, they're going to be a challenge, they're going to be risky, and I have to approach it differently than I would, say, a German Shepherd. So I have a different set of concerns in my head the minute that patient walks in the door. So we're going to break things down into these categories. And obviously, human error starts with your preparation. And this is why I got on you guys 2 or 3 weeks ago when I heard that people were going into radiology to sedate patients unprepared. Now, I don't expect you to know everything, but you should have a note card with your normals, and you should have some notes about the drugs so that you know what are the effects of the drugs you're using, and that's part of your training. So that's why you guys are going through this training. So when you do anesthesia, you're going in with some knowledge of what you're doing. We don't just pick anyone off the street and say, anesthetize this dog. It takes a level of training. And then if you are not familiar with your equipment or agents, I tell you on externship, one of the first things I say you do day one is find that anesthetic machine, because it's going to probably be different than the one you used at school, and familiarize yourself with it without a patient on it. I mean, you don't want to walk into a procedure and you've never touched the machine before. You need to familiarize yourself with the equipment and what are the drugs. Now, I've talked about a lot of drugs that you need to know for the board exam. When you go into practice, you're not going to be using probably that entire list of drugs. Your doctor is going to choose drugs that they want to use. So the other thing, day one of externship, write down the or take home a list of the anesthetic protocols and look up those drugs. What are the effects of those drugs? What are the effects of those protocols? Taking a good history and making sure we do a good physical exam. If we don't get a history and we don't know that this dog was sensitive to acepromazine, or we missed a heart murmur, or we missed respiratory distress, it's going to cause a problem. And then a big thing is your drug calculation and administration. So normally you have someone check your math, because we all have good days and bad days, and everybody is capable of, drawing up the wrong amount. I mean, I told you guys the story of me giving the wrong amount to a cat in intensive care. It was late, I was rushing, and I grabbed the milligrams instead of the mils, which is 10 times the dose. Now the cat did fine, luckily, but it was an error. Now I was by myself, but you might want to just say, especially when you're starting out, can you check my math? Can you check my syringe? I just want to make sure. And then obviously the big things I worry about is, are you too tired? Are you trying to go too fast? And are you not paying attention? One of the reasons we want you guys to get calculators or get good at doing math in your head, you don't want to be out on your phone. You don't want to try to use your phone for stuff like that. And you don't want to be talking to, if you're sitting there, I've seen a lot of anesthetists and they're completely watching the surgery and they're talking to the scrubbed in tech, or they're talking to the doctor. Oh, this is what I'm doing this weekend. Oh, did you see this movie? I like this new song. And it's okay to have lighthearted conversations, but I'm always looking at my patient. I'm always looking at my monitor. So I'm not saying that you can't have conversations, but things can change quickly and you have to be paying attention. And then a big thing that we worry about is equipment error. So did you check your oxygen? Did you use the proper, inhalant in the machine? The pop-off is very dangerous. Now, you guys are lucky that let me get to the next slide, because equipment failure is an issue. Let me come back to the pop-off, but you have to make sure your carbon dioxide's fresh, because they'll rebreathe CO2. Did we check our oxygen? Make sure we have enough. And then, is the ET tube clear? Now, if you're worried about the tube being blocked, one thing you can do is, you're going to have your tube and you're going to have your Y piece. Disconnect it, and you might smell a little bit of gas, or you can, here are tissues. You can take a little gauze and you can watch to see, is there air moving? Do you feel air? Do you hear air moving? So that's something that you want to check if you're worried about the tube. Now, think about it. If you are having issues where in a tube, they couldn't breathe through the tube, you'd probably see abdominal breathing. They go. So if you see an exaggerated, and animals shouldn't be breathing hard under anesthesia. If they're intubated and they have adequate oxygen and they have an adequate bag, there shouldn't be difficulty. And so you have to start investigating. Is the tube too small? Is it blocked? Make sure. And I have had to change tubes in the middle of anesthesia. The animal's upside down and it takes a little practice, but you can extubate them upside down and re-intubate them on a table if you're truly concerned. And always communicate with your doctor. I know sometimes when you're new and you're in practice and maybe you don't know your doctor yet, some techs are tentative they're interrupting the doctor. That's their patient. And the surgery they are doing means nothing if the patient is not alive. A beautiful surgery does not mean anything if the patient goes into cardiac arrest. So interrupt the doctor, say, hey, I'm concerned. And it's okay to be wrong. And sometimes people feel stupid. I've made bad calls before where I was like, wow, I was off base, but I'd rather err on the side of caution and say something than to not say something because I was afraid of sounding stupid or I was afraid of making a mistake. Vaporizers, as long as you take care of them, they work well, but you can put the wrong one in. Remember, they are specific to their agent, and you cannot tip it. Sometimes people roll machines back and forth, and if it falls over, it tips. Inside the vaporizer, there's very sensitive equipment, and that needs to be sent off. That needs to be cleaned and recalibrated. So if you tip it or it falls over, you have to tell somebody, because there is a high chance that when you turn on the vaporizer for the next patient, you don't know that 3% is actually delivering 3%. It could be more if there's damage, and you're not going to know that. Most of the time we don't. There is a little machine, a little adapter that will measure how much percentage of gas is coming out, but not a lot of clinics use those. So when you put it on 2% ISO, you are taking the machine's word for it that they are sending out 2% isoflurane, okay? Don't overfill it. And the other thing to mention, some clinics will have a machine that has an ISO vaporizer and a SIVO vaporizer right next to each other. And if you leave one on and you turn on the other, you will run 2 anesthetics to your patient. So normally what we would do at Purdue is I would put a piece of tape over the one I wasn't using so that you couldn't turn it. Okay, so you always want to make sure you're using one or the other, and mark the one that you're using by putting tape on, and you could just move the tape back and forth. But it will run 2 agents if you have 2 vaporizers on the same machine. We don't have any of those at school, but some practices have them together. Fastest way to kill a patient is to leave your pop-off closed. Because what happens when an animal exhales, okay, some goes into that rebreathing bag, but some goes out through the pop-off and it goes out that blue hose, the scavenge system. And I think enough of you have now worked with machines and done your project for surgical nursing, and you've seen that blue hose, and it either goes to an F-air canister or it goes to the ceiling at school. If you have a pop-off that closes, what happens is it can only go to the patient and the bag. There's no way for it to escape. So, and the problem is you have oxygen on running continuously. So that pressure is going to build, and it's going to build in the chest. And what happens is the lungs are going to fill and fill and fill. 2 things: you can pop the lungs, where you could get a little, damage to the lungs. It's called barotrauma, or those little alveoli pop and you can get a pneumothorax. But probably what's going to happen first is you're going to stop the heart, because the heart is sitting between the lungs. If the lungs compress, they will actually stop blood flow to the heart. Now, at school, you guys have the little button. And in my video that I've recorded, you push the button down, you squeeze the bag, and then you let the button up. Now, all of those machines have the capability to turn the pop-off closed, but the only time you close the pop-off like that is when you're leak testing the system. Other than that, you guys should use the little button. But when you leak test in the morning, this is another big mistake. You go in the morning, you close that pop-off, you test your machine, and then someone says, "Oh, hey, Christine, where's that patient?" And then you turn around and you start talking, and then you get busy, and then someone goes to start the patient and the pop-off was closed. I've gone into the OR 3 or 4 times this term. 3 or 4 times I've had to go into the OR and pop-offs have been closed. And I think what's happening is you guys are going in and doing your machine project where you have to leak test, and nobody is opening it up. Now, if Mrs. McClure goes in there to do a procedure on a patient, now obviously she's probably going to check the machine before she uses it. But you see what I'm saying? If you leave it closed, the next person goes in there, hopefully they check it, and they should, but you have to be careful. So I'm telling you guys, a pop-off is a serious thing. And a lot of clinics out there have old machines. They don't have that little button. So to bag your patient, you'll close it, squeeze the bag, and then you'll open it after every single time. Okay. Oops. Sorry. Okay, so the other part of anesthetic emergencies is making sure that we pick a good protocol for the patient and the procedure. And really, when we look at all the drugs that we choose, is there any side effects or contraindications? I've talked about propofol drops the blood pressure. And if I have a patient that has low blood pressure, I'm either going to use a low dose of propofol or I might choose another drug. Or if I have a dog that's already bradycardic or has heart disease, I'm not going to choose dexdomitor because it drops the heart rate and it has such high cardiac effects. So do you see, when I've told you about drugs, I've told you about some of the glaring kind of like side effects. Opioids, you have to be cautious if your patient has severe respiratory depression. Sight hounds, we never used barbiturates. Ketamine, cats with kidney disease. So do you see where I'm getting with? So you have to be familiar with the side effects of the drugs that you're using and the contraindications to any pre-anesthetics or general anesthetics. Now, I've said this on day one. When I've worked at Purdue and I've worked in practices, once the doctor got comfortable with me and our anesthesiologist trained us, I did pick drugs for patients, but these were a list of drugs that are already pre-prescribed as anesthetic protocols. So technically the anesthesiologist has prescribed these drugs. I'm carrying out his wishes. Now, if I had a patient that was very out of the range of normal, or I was concerned, I always went to the doctor and said, are you okay? Are you okay if I use ACE? I'm going to use a quarter dose. I'm not going to use propofol. I've decided I want to use Cat-Val. So, there's always a dialogue. I mean, ultimately, when you guys are first out in practice, your doctor is going to choose these protocols. But the problem is you're the one doing anesthesia. You're the one discharging the patient. You're the one talking to the client. So you still need to be familiar with the drug you're using. And are there any contraindications? And there are times where I've had a doctor, maybe a younger doctor, and I've said, I don't want to use that. And they're like, oh yeah, like it triggered something with the doctor. I mean, they're very smart, but a good team, a good doctor listens to their technicians and their technicians respect the doctors. So most of the doctors I've worked with in my career, we've always kind of talked about protocols and we've come together, and a majority of them now respect my experience, and you will get there. So it kind of just depends on your clinic, but it is upon you to know the drugs that you are working with. Your patient depends on that. The owner of that dog or that cat or whatever, turtle, mouse, sheep, horse, cow, whatever, is trusting your practice, and you're a part of that. And again, people don't seem to understand this concept sometimes. Not you guys, but sometimes people are like, well, I just want to use ketamine because I don't want to give a dog all these drugs. It is much safer to use multi-drug or balanced anesthetic protocols. It's called, remember, multimodal analgesia, balanced anesthesia. It's like making soup. Okay, if someone is not supposed to have salt, I don't want salt to be my only ingredient. I'm going to use oregano and pepper and garlic and onion powder and whatever. In this situation, if I use ACE and butorphanol together, I use lower ACE and I use lower butorphanol. I use those drugs in lower amounts and it results in a safer protocol. If I just use ACE by itself, you have to use a much higher dose, and the higher your dose, the greater the side effects. Now, one book, I'm going to tell it right now before I forget. All of you, when you go to your externship, most of your practices probably have that drug, the Plum drug handbook. They probably have it. there. But I would personally bring my drug handbook, because that, like the night that I overdosed that cat, I went and got Plum and I looked up the overdose amount and I calculated what I gave. I was overdosed, but I was under the danger level. And then I looked up what are the adverse effects, because if I'm going to overdose something, what am I looking for? So that Plum is such a great resource for you guys. You should be lucky that it's part of your books. You should keep it forever. It's a great resource, but it's up to you to look at that. Now I'm going to get into patient high risk, because these are all either categories of patients or procedures that are riskier than the average everyday patient. So we're going to break it down to how do we treat these animals, what makes them unique, and what should our approach be. So if I get into neonates, and there's always kind of a controversy as what is considered a neonate. Technically, neonates, I always think of as 8-week old or 2 weeks old. And then it says pediatric. Well, I classify pediatric as like 6 months and younger. But really, if you're doing something around 3 months old, 2, 3, 4 months old, we're getting into the neonatal pediatric. Now, these guys, what do we see them for? Well, it could be a PDA, which is the patent ductus arteriosus. It could be a bad umbilical hernia. It could be a trauma. It could be an early spay or neuter. So this isn't a common category. These guys aren't coming in for dentals, but it could be a foreign body removal. I mean, puppies like to eat everything. So one thing is pre-op fasting is these guys are younger, so they're prone to hypoglycemia. So I want you to be able to tell me, for these categories, you guys have to be able to tell me at least 2 considerations for every category I'm going to go over. So I'm worried about fasting. Usually we do not withhold food, and normally we don't pull water until that morning. So normally they can have water up until that morning. And this is always doctor dependent. I tell you, I always check with my doctor, what do they want me to tell the owner for fasting? The problem is, in practice, usually your receptionist, it is the receptionist's job to call the surgery patients for the next day. And most of them just go down the list and they don't look at, this is a geriatric, this is a pediatric, this is a brachycephalic, this dog has kidney disease. They just go, Fluffy, Rocky, Bo, AJ are all coming in today. So if we ever had patients that fell out of the normal, they usually had the technician call, because I know more details about the patient, and maybe not every patient is made the same. So that's just a little tip, is if your receptionist is the one calling these guys, make sure the receptionist is aware, or say, hey, you know what? AJ is only a 4-month-old boxer. I'm going to call Mrs. Landeros because we don't really want to fast AJ. Okay, then I know, and instead of just getting a call. Usually, and then this is dependent on the patient, but a lot of times these guys are put on a 5% dextrose strip. We usually add sugar to the fluids. Now, again, they might come in with a normal blood sugar. So if they did come in normal, sometimes my doctors didn't do this except if they were really, really young. And then be very cautious with the fluid pump that you use, because if you put them on a regular drip, a 10 drop per mil, and you set the rate wrong, you can overhydrate these patients and you can drown them. A little tip, I told you about that patient that we fluid overloaded at Purdue because they set the pump wrong. I normally set my pump, it'll tell you how much fluids you want to deliver. I can put in 100 mils, 500 mils, 1,000 mils. I always use a little bag for pediatric patients, and I always only put in a very small amount to be delivered. That way, if I set it wrong, it's going to stop and alarm me. So I'm not going to put in 1,000 mils because that's what happened with that patient. So that's just a little safety tip that I used to do in ICU, is the little guys, I didn't put a lot of fluid into them. I'd rather keep going and resetting the pump and it alarming at me than do it wrong and overhydrate. And then you want to be careful with your gram scale and weighing them properly. So definitely may need to use a gram scale if you think they're less than 10 pounds. But your clinic may only have a baby scale, which is fine. You just don't want to put them on the big dog scale. So most clinics have a little baby scale for like cats. Use that. And then sometimes we dilute out our injectable agents if, it's too small. Sometimes these are small amounts. You can sometimes add a little bit of saline. One thing that we have to watch for is any drugs, is if we have drugs that are highly protein bound. I talked about propofol. I've talked about Valium to some degree. Pentothal used to be really bad. Alfaxin to some degree. These drugs that bind to plasma protein, we have to make sure, because sometimes these guys are low protein and they don't have a fully functioned liver. They don't have a fully functioned kidneys. So when we use drugs that require heavy liver metabolism and kidney metabolism, it can affect how long the drugs stay in the system. I liked propofol in these guys. Opioids were pretty safe. Midazolam is a good drug because they don't have a lot of side effects. But I would always use, personally, when I have a neonate, I always use a lower dose. If the drug was supposed to be 4 mg per kg IM, I might give 2 mg per kg IM. I might cut it in half because you can always give more. So when in doubt, with neonates, geriatrics, any patient, if you're concerned, just give less, because like if you use a drug like ACE, it doesn't reverse. So you're stuck with your effects. I'd rather have to give more than unfortunately give too much. So you can use inhalants. They do have a high risk of getting cold and a high risk of low blood pressure. Also, they can have low oxygen. Now, one thing I want to mention, physiology, I've told you guys over and over again. You got to know your physiology. Puppies' blood pressure is dependent on their heart rate. So in an adult animal, when they have fluctuations in blood pressure, the blood vessels can adjust their diameter and can compensate. When a puppy starts to have low blood pressure, the heart is usually going to pump faster and harder because they don't have the baroreceptors in their blood vessels to compensate. So what happens is when a puppy gets a really low heart rate, they tend to have a really low blood pressure. That doesn't tend to happen in adult patients. So in neonates, I'm going to tell you, I watch their heart rate like a hawk, because when their heart rate drops, so does their blood pressure. So what are things that cause a drop in heart rate? Now, this doesn't pertain really to dextomator, but if I have a cold puppy, I usually have a very bradycardic puppy. So you want to try to keep them warm right from the get-go. If you guys remember, I told this story once before when I talked about atropine. We had a big liver surgery at Purdue on a 4-month-old. I think it was a Yorkie or something. And it was a liver shunt, and it's complicated surgery. And the dog, you have to open the abdomen, you have to take them to radiology. They get cold. The dog was 88 degrees, which is very, very cold. And, I was battling it, and the dog's heart rate kept dropping. The blood pressure was dropping. And I was like very concerned. I called the anesthesiologist. I was like, you got to come help me with this case. And basically, I gave it atropine and nothing happened. So I gave it another dose of atropine and nothing happened. I gave it 3 doses of atropine, no change in the heart rate, because at that point, It's like hypothermia. Like if a kid falls in a pond, the way they survive is their body temperature drops and the heart rate and the brain function, it only maintains enough blood flow to maintain brain function, and the heart doesn't have to pump as fast. Now, once we got this puppy warmed up, then the heart rate started to come up and the blood pressure came up. So my big thing in neonates, watching their glucose, keeping them warm, watching their heart rate and blood pressure, and using lower doses because you can always give more. And watching for don't watch your fluids close. Watch them, watch them, watch them. Now, geriatrics, I want to say something about geriatrics because this is a patient that's maybe reached 75% of their life expectancy. Now, in a cat, you know, most cats, we think, how long do they live? To be maybe between 14 and 16. I mean, you always hear of those cats. I had an 18-year-old. I've had two 18-year-old cats. And then I had one die at 12, and my last one just died at 13. So in cats, it's kind of fairly universal. I would consider a 12, 13, 14-year-old cat geriatric, personally. Now, dogs are all over the place. I mean, a Chihuahua is, you know, an 8-year-old Chihuahua is middle-aged. An 8-year-old Great Dane is ancient. Do you see what I'm saying? So in dogs, that life expectancy is going to vary. Obviously, the little guys live longer, and the, you know, large to giant breeds have shorter lifespans. You know, like I said, I would say a 5 to 6-year-old Great Dane is fairly geriatric. A 5 to 6-year-old Golden Retriever is in his adult prime. I might consider like an 8 to 10-year-old Lab or a Golden getting geriatric. So, but I want you to burn this into your head. Age is not a disease. Age is not a disease. A lot of people are afraid. A lot of clients are like, I don't want to get a dental done on my dog. He's too old for anesthesia. I had a 17-year-old dog get anesthetized for a brain tumor 16 times in a row that did better than some of my 10-year-old dogs. I mean, that dog was an anesthetic textbook picture. His EKG, blood pressure, and this dog was 17 and had a brain tumor. And the lady had a birth certificate. It was like a shepherd mix. We were all, and it walked like it was 17. I mean, you could tell that dog, anesthesia was like this. So boring. Okay, so that dog did great. Now, one of our students, he messaged me the other day. He adopted one of the pitties, Nick. If you guys remember Nick, bald, glasses, and he had taken, I can't remember the dog's name, I feel bad. Rusty just had a mass removed while he's on externship, and he had messaged me, and he's an old guy, and I just told him, I said I'd watch your doses, and I'd keep him warm, and I'd keep him low on the anesthetic gas. He said he did perfect. Anesthesia was like a book. So I'm just telling you, don't be afraid of geriatrics. There are concerns, but done a lot of geriatric anesthesia in my day, and a lot of them do really, really well. But they have an older heart, older lungs, older liver. So those organs are aged. Now, these dogs can have good heart function, but it's a little bit older. Could have some degenerative joints, degenerative muscle. They don't like to be stressed, and stress can predispose to arrhythmias. So I want to, the thing is, and I've been better as I was an older tech than a younger tech, to take really good care of these guys, give them really comfortable bedding. Sometimes under anesthesia, people position dogs really crazy, like yank their legs. And I'm like, these guys have old hips. And I used to have these radiation patients, and they'd wake up and walk, because for radiation, I have to put them in really weird positions sometimes. And when I was done with the anesthesia, I would always massage their legs, and I'd massage their hips, because I just felt bad. I'm like, sorry, I had to contort. This one dog, I had to pull a limb, and you could feel the shoulder pop. So I would just sit there and rub the shoulder. And, I just think about, maybe it's because I'm getting older. I don't know. So typically the big thing with geriatrics is I reduce my doses. I can't say don't use this drug. I mean, a lot of people in geriatrics, they do stay away from the alpha 2s. They tend to stay away from dextrometor. I know Nick said they used ACE and morphine in his dog and propofol and ISO. I don't have a problem with ACE. I use a lower dose. ACE is metabolized in the liver. Hopefully the blood work is good. I watch blood pressure, because that's another thing, and I want to stress this, is these guys have kidneys that might be teetering on, borderline renal failure. But I've told you at least 75% of the kidney needs to not be functioning before you have an elevated BUN. So you can have a normal BUN and your patient might be right under renal failure. So, but the biggest thing to preserve kidney function during anesthesia is a good blood pressure that stays above a mean of 60 and adequate IV fluids. So these patients needs to be on fluids, okay? And I use lower doses, lower propofol. You can always give more. Lower ACE. That's what I told Nick. I said, just cut your ACE in half. They may take longer to recover due to the fact that, altered liver or kidneys, they tend to get colder because they don't have as good of muscle. As they age, they lose muscle mass. So their ability to shiver, their ability to stay warm is altered. So keep them nice and warm. Fasting, it is okay to fast geriatrics, but I will tell you one thing we do, and it's not on the slide, is we let them have water till the morning. Unless I have a patient, and I always ask the client, I go, is your dog like a guzzler? Like, do you give them a bowl of water and it's gone in 10 minutes? If you've got a dog that excessively drinks, and they might come in with a stomach full of water, then you might want to withhold water. But the thing is, a lot of these guys, the reason their kidneys are hanging on is their access to water, especially cats. Okay, old cats, their access to water is critical to maintain their kidney function. So I don't withhold water in cats. Usually not on dogs unless they were a guzzler. You can usually pull food, but I try to make sure, a lot of people feed their dog dinner at 5 or 6 o'clock. Then if they don't feed anything, they may not bring the dog until 7 or 8 a.m. So they've gone over 12 to 14 hours without food, and then you might not do the surgery till noon. So that dog has gone quite a length of time without food. So you might want to give these guys, I usually say, why don't you give them like a late dinner? Like give them something around 10 o'clock, stay up. And that way they haven't fasted quite as long as if you stop feeding at 5 or 6 p.m. So be cautious there. I've mentioned a little bit about obese animals, and you always, and this is the category, or this is an area where students tend to get wrong on drugs, and I'll talk about. But you always want to weigh the animal, what they weigh currently. If I have a 100-pound Labrador, and I'm like, he's probably supposed to be 80 pounds. And your vet might do this, or you'll get comfortable guesstimating weights. Then what you're going to do is you're going to usually calculate your drugs mg per kg on ideal weight. So when I calculate the anesthetics, I calculate them for an 80-pound dog. So a lot of these anesthetics, some of them do go to the fat and some do not. Propofol does tend to go to the fat, but it's not like it's stored there like some old drugs we used to use. One big thing I worry about is the respiratory issues. I got called in, I was helping out BCA in the ER, and I was getting called in to help supervise and train ER techs during surgery. And they call me in this night and they got foreign body, and I walk in and it's a barely looking, puggy, Frenchy looking, pseudo brachycephalic, but this dog has a barrel chest and a huge belly. And I'm like, oh my God, I said, he's going to give me a nightmare. And sure enough, he did these really shallow, like little breaths, had super high CO2. We had to ventilate him quite a bit to keep his CO2 down. So the problem is the belly pushes on the diaphragm, and you have a dog that's going to be, you're doing anesthesia, they're going to be respiratory. Oh, shh. You have a dog that's going to be respiratory depressed because they're under anesthesia. So they're not breathing with all of their strength. And then you have this belly that's pushing on their diaphragm. So we're kind of like already two things in the hole. Too much weight and not adequate ventilation. So what we tend to see is these guys do these little, and this is exactly what that dog did. Now the respiratory rate was in the 50s to 60s, which is, I don't want a respiratory rate that high. If this dog was sleeping at home, would it be breathing that often? Probably not. So they do these rapid, shallow breaths, and then what happens is, because they're tachypnic, they're not taking in deep breaths and CO2, hypercapnia, your CO2 is too high. So what we have to do is we have to bag them more often and bag them more to get that CO2. And I use my CO2 as my guide. The more I breathe for them, it's going to help bring that CO2 down, and you're going to breathe deeper. Not past 20 centimeters of water. Now, I will get into some of the I'm going to talk about the brachycephalics. I don't know why it's in the middle of this slide right here, but let me talk about the brachycephalics. Okay, so you probably want to highlight this because I don't like that it's buried. I'll have to fix that. And as the high-risk patients, brachycephalics, I've already told you about anatomy. Because everything is smushed, they tend to have a short nasal passage, a shortened pharynx. The big thing is the long palate. They tend to have a very long palate, and it almost like when you go to intubate them, you pull out their tongue, and you don't even see a trachea because the soft palate looks like a big curtain hanging in. That's why they snore. That palate. Hey! Hey! Sorry, I didn't mean to yell in the camera. This big palate acts like a curtain, and then they breathe back and forth. So, one thing is that, we want to get them intubated, very, very quickly. So hang on one second. Sorry. Okay, so sorry. So let me talk a little bit about some other things that we worry about. Now, there's something here that say avoid agents that depress respiration or relax the muscles of the pharynx. When we use pre-meds, if they get too deep, they could aspirate prior. But when you go to anesthetize them, you need to have a very relaxed larynx. So we're talking about two different time frames. But generally, I use lighter pre-meds in a brachycephalic, and then when I use my induction agent, I use something very rapid like propofol. I often quizzed you guys, and I said, what agent would I not want to use to anesthetize them? I'm not a fan of ketamine and Valium induction because ketamine, they retain a little bit of their swallow, which can make an animal more difficult to intubate. And these guys, right when you anesthetize them, they can turn kind of blue and cyanotic, and what you need to do is get a tube in and start them on oxygen fairly immediately. So the other thing is induction is going to be very challenging. You want to have everything ready. Usually when I pick an endotracheal tube, and they use smaller tubes, so I will say brachycephalics range, like a Frenchie might take a 5, a bulldog might take a 6 or an 8, depending if they're little or big. So you can't say, I can't say all 80-pound dogs get a 12 endotracheal tube, because I can tell you an 80-pound Labrador would probably get a 12 or a 14. An 80-pound Bulldog would probably get a 7 or an 8. Weight does not correlate to endotracheal tube size. The other thing is I like to try to give them oxygen right in front of their face for about 5 minutes before induction if you can. It gives them a reserve of oxygen. It's called pre-oxygenation. Now, I don't want you to put a mask on with oxygen and have them stressing and fighting the mask, because if you create stress during pre-oxygenation, it does no good. So these are animals that I'll normally kind of like put the tubing in front of their nose, just let them inhale some oxygen, and then I give the propofol and intubate. And you definitely want to use a laryngoscope, because you're going to need light back there. They're very hard to see. Their airway is smushed and everything kind of looks smushed together, for lack of a better scientific term. And you want to be able to visualize. And remember, I always choose the tube I think I'm going to use, which you can put the tube in between the nares, or you can feel, and then I always pick one smaller and one bigger. I don't ever lay out one tube for these guys. Always have your tubes, and make sure you check your cuffs before intubation, because you don't want to put a tube in and then realize the cuff doesn't work. The other thing is deflate your cuffs. I've seen people in noose and all their cuffs are inflated, and then the dog's asleep and they're sitting there deflating their cuffs. They should all be deflated and ready to go by the time you give your propofol. Have everything ready, oxygen tubes. And then when we talk about post-op, you want to make sure that, it's best to use agents where they wake up quickly. We tend to avoid like dextometor and heavy pre-meds, or use very low dextometor. I always have oxygen nearby recovery if they're having trouble breathing. And you want to watch for any difficulty, any abdominal breathing, flared nostrils, and make sure that they're very stress-free, quiet area, but they really need to be observed. Especially when I end up pulling, and I don't just wait for 3 swallows. These guys have to be pretty much sitting up and able to hold their head up. Because think about it, if you pull a tube and a dog falls asleep and they can't breathe, can they lift their head? It's kind of why you don't put babies on their stomach in a crib. Because if a baby falls asleep on its face, do they have the strength to lift their head and get air? This is what I'm talking about. These guys can get in awkward positions, and they have to be awake enough to be able to move themselves to breathe. So no stress, and we want to be really cautious during recovery. A sighthound, there's not a lot written here. So these are your greyhounds, borzois, Italian greyhounds. I think collies are long-haired sighthounds. They tend to be just more sensitive to anesthetics. Now, I teach you guys about pentothal. Even though you can't use it on a board exam, pentothal cannot be used in sighthounds because they lack the fat component. And when you give pentothal, some goes to the blood, the brain, and the fat. If you don't have the fat, you have more available in the blood and the brain, and they can get very deep. So we decrease our dose. Now, propofol doesn't tend to do that. So I tend to use propofol or ketamine Valium in sighthounds. But when I give them pre-meds, they're more sensitive to ACE. Midazolam or diazepam, is a good pre-med. Low-dose ACE promazine. Opioids, I usually go full dose. Propofol, I will usually calculate a 6 to an 8 mg per kg dose, or Alfaxin. But when you give propofol and Alfaxin, you're going to titrate it to effect anyway. So I don't necessarily decrease my dose that I draw up. I just give it to effect. And usually these guys will end up needing less. And they watch for malignant hypothermia in greyhounds. And keep them very well padded. And they tend to be high stress dogs. So make sure they recover quietly. Helps with anesthesia. Now, cardiovascular disease in patients is very broad because this is cardiovascular. So this is any blood. Bo! This is any blood disorders, coagulation disorders, blood pressure disorders, heart disorders. So anemic animals, one concern I have is if they're anemic, why am I concerned? Red blood cells carry oxygen. If I have less red blood cells, I theoretically have less ability, I can't carry as much oxygen. So anemic patients, I've done anesthesia on anemic patients, but I watch their oxygen levels very closely. Sometimes we give these guys a blood transfusion before surgery. It kind of depends on why they're going to surgery. Shock, if they come in hit by car, dog fight, and they come in very tachycardic, low blood pressure, that's a vascular issue. You need to give them IV fluids, give them pain medication, maybe prior to surgery. Now, cardiomyopathy, remember, there's two forms of cardiomyopathy. Hypertrophic is where the heart gets too thick, and that tends to be cats. And then dilated cardiomyopathy is where the heart is really big and kind of flabby and flat. It doesn't have a nice strong muscle. So there's hypertrophic, which makes your chamber size too small. And then there's dilated, which your heart doesn't beat as strong. Both can affect perfusion. So we have to be very cautious. And then there's congestive heart disease, like heart failure. A heart murmur, those dogs tend to have, if they have mitral valve disease, they can have low cardiac output, which affects blood pressure. So it all kind of ties together. So what are the problems that we can see with them? Well, we can definitely have low oxygen because they don't have enough red blood cells or good perfusion. If you have an animal that's hypoxic, it can be the oxygen isn't getting to the tissues, either because of low blood pressure or not enough red blood cells. High CO2 because you have impaired circulation to the lungs. Therefore, the body isn't getting rid of CO2, it's building up. You need adequate circulation to get the CO2 to the lungs to be exhaled. Electrolyte imbalances and hypothermia, because hypothermia can be due to poor perfusion, which is a blood pressure. So this is a lot of you guys putting mentally together all the physiology that you've learned in all of the heart diseases. Vagal stimulation. Now, vagal stimulation tends to happen usually during intubation. Sometimes the surgeon pulls on the stomach or tugs on the esophagus and they can cause vagal stimulation. Brachycephalics, especially bulldogs, have a high vagal tone, and dachshunds. Those are all breeds that tend to have a lower heart rate or are prone to vagal stimulation, which causes a bradycardia. And obviously, if you give them too much anesthetic and you drop their blood pressure too much, you can cause hypotension by giving propofol too fast, by giving too much propofol, by overdosing acepromazine. So some of these low blood pressure, poor perfusion comes from the drugs that are actually being used. So what do? We do a good evaluation prior, listen to the heart, do an EKG, take a blood pressure, feel for their pulses. What is their color? In their history, is there a history of exercise intolerance, coughing, pale mucous membranes? These are all cardiovascular assessments that we have talked about. And then any laboratory changes, you want to check your PCV. Do I have a normal PCV? Do I have normal? Some clinics are doing, there's a cardiac enzyme test called BNP test. It's a SNAP test that if you suspect heart disease, obviously if we suspect heart disease, you're going to do an x-ray or you're going to want to do a cardiac ultrasound. Not every clinic can do, most clinics should be able to do an EKG. Usually if we suspect severe heart disease, we usually try to send them for an echocardiogram prior to doing anything, but you don't always have that capability. But you can do that BNP SNAP test, and it does test for some cardiovascular function. Big thing is the heart rate. And I hear people say count 6 seconds, multiply by 10, because they act like they don't have time. Count 15 seconds, multiply by 4. If I'm really concerned about the heart, I count 30 seconds and multiply by 2. The longer you listen to the heart, the better you're going to pick up a rhythm. Now remember, there's speed up and slow down, which is a sinus arrhythmia, which is normal as long as it happens when they breathe. It should follow their respiratory pattern. You also want to look for synchronous pulses. So I listen to the heart. Do I feel a pulse every time I hear a heartbeat? You kind of got to get coordinated to do that at the same time. But that's part of doing a very thorough exam. Now, one of the things that we deal with in anesthesia is we tend to deal more with bradycardia than tachycardia. Okay, so an animal, remember, tachycardia does not always happen because they're light. If an animal has really low blood pressure, the heart rate will speed up to improve the blood pressure. So sometimes tachycardia is because they're too deep and they have low blood pressure. But I worry about bradycardia. Bradycardia can be because they're too deep under anesthesia. Now, bradycardia comes from alpha 2s, and that's very normal. But that's part of, stop it, go. That's part of when you understand your drugs. Remember I told you guys, please remember this. If I'm doing anesthesia and my dog has a heart rate of 40, I better see that he got dexdomitor. Then I'm like, that's probably why the heart rate's 40. If I'm doing anesthesia and the heart rate's 40, say it had been 80, and there was no alpha 2 on board, it could be they're hypothermic and their heart rate's dropping. It could be that they're too deep, or it could be that there was a vagal stimulation. Okay? Not a lot of your heart rate is always going to be slower when they're anesthetized than when they're awake. So when their heart rate, like, I'm going to give you an example. A lot of times I anesthetize a dog, their heart rate goes up because they're excited. As I start prepping them in the prep room and clipping them, their heart rate goes to 120 to maybe 91 to 87. And then a lot of times it levels out around 80. So my heart rate went from 120 to 80, but then it goes like this. And it goes like 80, 78, 82. It kind of hovers. But I'm like, okay, it's lower. But if I have a heart rate that was maybe 120, it goes to 60 into 50 into 40, that's a pretty rapid decline. You need to look at that. Okay, so, and again, whether you're going to give atropine or not to treat the bradycardia will be up to the doctor, but normally the treatment for bradycardia, like vagal stimulation, is atropine. Anesthetic depth, you turn them down, you give atropine. If they are bradycardic when they got an alpha 2, the best way to treat that is reversing it. Some people give low dose atropine, and that is a 50-50 bag. I think Dr. Ritz and maybe even Dr. Paul prefer to give some atropine when that happens. I and the anesthesiologist I worked for, we would try to turn them down or give a partial reversal. It really depended on what their blood pressure is. If they're bradycardic and they have a good blood pressure and good color, I'm less concerned than if they're bradycardic and they're pale and they have like a crappy pulse. So you have to be cautious there. And then let's get into respiratory distress, because this one sometimes is hard to figure out. Now, normally under anesthesia, the patient is intubated, they're on a breathing system, they should have a clear airway, they should be getting oxygen, it should technically be easier for them to breathe, but we've given them drugs. Almost every anesthetic that I've talked about, pre-med, induction, and inhalant, all depress respiratory function. It's the degree of depression that we're looking for. It's okay if my patient was breathing 24 times a minute during its TPR and it breathes 8 times a minute during anesthesia, I'm not concerned. It is anesthetized, it is depressed. That is a very normal rate under anesthesia. I don't usually worry until we're getting much below, like, if we are at 6 breaths a minute, down to like 4 breaths a minute, that's pretty low. But I mean, I've even been comfortable 8 breaths a minute. But you have to take all of your parameters into consideration. Do they have good color at 8 breaths a minute? Is their abdominal effort normal at 8 breaths a minute? Okay. So is their CO2 okay? Is their SpO2 okay? Look at all of these values when we assess their respiratory rate. Now, if an animal comes in with respiratory depression or distress, I should say, I'll stop saying depression. If they're having a hard time breathing before they come in, that really needs to be looked at, because that dog might need oxygen or x-rays, or they might need some support before anesthesia. So you may have to delay the procedure. NO2, which should really say N2O, is nitrous oxide. Now, if we have respiratory distress, now not a lot of people work with nitrous anymore, but nitrous competes for oxygen space. So when you give nitrous, it likes to go into the alveoli and kick out the oxygen. It's kind of like, hey, this is my space. So the higher that you run nitrous, it's going to compete for oxygen. So like what we used to do is, if my patient was going to get a total of 1 liter of oxygen, if I had nitrous, I might run, hang on a second. Okay, sorry, my dogs are being absolutely crazy tonight. I apologize. So one thing, so I'm talking about respiratory distress when animals come in, and then I'll talk about what happens if they have it during anesthesia. So one thing you want to always assess is a PCB, because is the problem, animals that are anemic, they're tired. Sometimes they breathe harder. And that's because they don't have as much oxygen carrying capacity, because they lack red blood cells. So usually what we're going to try to do during surgery is definitely, I always breathe for them every 5 to 10 minutes, usually every 3 to 5 minutes. You may have to breathe more. Keep a very close eye on your SpO2, your oxygen saturation. So you want to have that either via, most clinics are going to have a pulse oximeter. Not a lot of clinics are going to have a blood gas. But remember, I talked about SpO2 is pulse ox. SaO2 comes from an arterial sample. So if you're working in an advanced practice or a surgical referral, usually those places will have the ability to check that via blood gas. But you want to try to do that. And then during the procedure, any difficulty breathing, using their abdomen, exaggerated chest movements, irregular respiratory rate, any cyanosis, do you see any blue, purpley, sometimes I just call it like a dusky color. It's not pink, it's not fully blue. This is huge for me, is the character. A normal breath should be like we're breathing. Remember that IE ratio, inspiratory to expiratory. Inspiratory is always shorter than exhalation. If they're going, that's a 3-to-1 ratio, that's flipped, and that's an abnormal, that's respiratory distress. One thing that when an animal is getting too deep, you're going to start to see a definite change in their character of breathing. Right before they die, it becomes much more of an abdominal diaphragmatic breathing than it does a chest. So watch their chest. Is it going up and down? Are they moving the bag adequately? Is the respiratory rate normal? Now, if I have a patient that's having trouble breathing, sometimes, if you remember, you should put the tube at the thoracic inlet. If you put it in too far, you are only giving oxygen and anesthetic to one side of the lungs, and that can be the reason for the breathing. This side is not getting oxygen. So sometimes you have to deflate the cuff and move your tube. So I always check my placement. I always make sure my tube is not kinked. Is it bent? Is the tube clear? If I disconnect them, do I feel air If you remember, I told you that case where I went in and the dog was massively abdominally breathing and the bag was super, super full. Now the pop-off wasn't closed. When I disconnected the patient, it didn't solve the problem. So if I have a patient that has a hard time breathing, it's two reasons. It's either machine and tube, or it's the patient. Well, when I disconnected the patient from the machine, the patient still had the problem. So right away, I don't need to spend 5 minutes looking at my machine because disconnecting the patient from the machine did not solve my problem. So one of the fastest ways to figure out an animal under distress, is it a machine malfunction? Is it a patient? Is disconnect them? Does it solve the problem? And when I did that, I discovered that the tube, they had overinflated the cuff. And when I deflated the cuff, it solved the problem. Always check your CO2 and your arterial CO2 if you can. But again, if they have too high of a CO2, did someone forget to change the soda lime? Is the pop-off closed? Is your breathing system hooked up properly? Okay, if your unidirectional valves are stuck, that's going to cause problems. So this is just kind of a list of problems that we can run into. Now, let's talk about some more patient factors. And now we're getting into actual procedures. So if we're going to do a cesarean section, usually, now there's two forms of C-sections. It's a lot of times how I've dealt with it, it's an emergency. The dog is in labor, not delivering puppies, a puppy is stuck, or she has what's called uterine inertia and she can't contract. If she's in, poor condition, sometimes you will have an owner of a bulldog or a French bulldog, and they will actually schedule a C-section because they don't want their dog. They know they usually have difficult births due to their pelvis and the big head of the puppies. So sometimes owners will just say, I want to bring them in for a C-section because I don't want to worry about problems. So, there's a couple different ways we do them, but often I'm focusing on the emergency side because normally the patient can be compromised, especially if you're dealing with someone that's not a breeder. Say their dog got pregnant by accident and they haven't read up on proper nutrition and care. The puppies demand a lot from the mother. She often needs 500 calories added to her diet. A lot of people will also feed pregnant mothers puppy food for the extra nutrients. So if the mother isn't getting proper nutrients and the puppies, little parasites for a better term, are sucking away, she may come in a very poor condition. So and a lot of times when they come in for an emergency surgeries have not usually fasted for the day. It could be an emergency splenectomy, emergency C-section, emergency foreign body, and we cannot wait for them to be fasted to go to surgery. So regurgitation and vomiting is always going to be a concern. Also, the uterus is pushing on the stomach. So these guys, have an issue because they are prone to regurgitation. And the other thing we have to worry about is any of the anesthetics that we give the mother, all of that blood is going to the fetuses. So I tend to try to use opioids that are reversible because you can reverse the pups. And what we tend to do is I tend to give very low doses to the mother. And I try to use low propofol, low alfaxin. And then when we take out the last pup, we'll give her a higher dose of like morphine or buprenorphine or something more powerful once that pup is taken out, because she just had major surgery. She needs analgesia. We just don't want to hit her with a heavy pre-med while the puppies are still in there, okay? A lot of times we worry about shock, and the reason we do is you have this giant uterus sitting on all their blood vessels, and the uterus holds a large amount of blood. So these guys can have low blood pressure due to, AJ! God, I'm so sorry. These guys can have issues with perfusion due to the uterus size, due to blood flow. So you got to watch blood pressure close, watch tachycardia. They need adequate fluids. And, the problem is, I tell you guys, treat dehydration, a lot of these guys have electrolyte imbalances, which can affect the heart. But the problem is we don't have time to treat the mother for all these preconditions because we got to get the puppies out. So sometimes we have to rush into surgery with a patient that is not the best candidate because we got to try to keep the puppies alive. So, and kittens, I'm focusing on dogs, but if it's a cat as well, or cow or whatever. So try to, one thing that you also want to do, I want to mention here, I'm focusing on the mother. When the puppies come out, you want to have, and when I talked about with you guys in ClinMed 4, I talked about the postnatal care, having oxygen. I always have reversal. If I use any opioids in the mother, I always have Narcan available for the puppies to get any narcotics out of their system if they're not breathing. So just some techniques. Now, a lot of times you want to check, we may have a patient with liver disease. Maybe they've been on pred their whole life. But the liver does a lot of important things like metabolize most of the drugs we use. They produce clotting factors, they produce protein, and help with metabolism. So we have to be careful with our pre-meds. Now, ACE is metabolized in the liver. A lot of the opioids, even though they go through liver metabolism, the opioids are fairly safe. But I usually use low pre-meds in these liver patients. And now ketamine, diazepam, it says avoid. Propofol is a good choice for liver patients because it goes through very little metabolism. Ketamine and Valium have to go through liver clearance. In the dog, about 50% of each of those drugs has to be broken down. Now, think about this. If I gave a normal dose of ACE to a liver patient, and they cannot metabolize it quickly, what is the consequence? They're usually going to take longer to recover because the drug will remain active. So the big consequence in liver patients is the drugs can have a more profound effect, so you use lower doses, and you may have a prolonged recovery because it takes longer. So you can do anesthesia in a liver patient. You just have to use caution with doses. Inhalants are just exhaled. So, inhalants are not going to go through metabolism. So like a propofol, butorphanol, midazolam pre-med, propofol induction, iso or SIBO maintenance can be done safely. You can usually get away with lower doses. And then kidney disease or renal disease is, kidneys maintain our urine volume, they regulate electrolytes, or they regulate our fluid volume. Because remember, fluid balance is maintained at the kidney level. Now, most drugs, they get metabolized and broke. Think about this. The liver breaks them apart into pieces. So now the drug is not active. Then some of it gets excreted through bile, but some of that drug that's broken apart is going to be urinated out inactive. Okay, the liver made it inactive. The inactive metabolites are going to be cleared through the kidney. So I need a kidney to get rid of my drugs. So one thing we have to be careful also with the kidneys is when they're anesthetized, it affects the blood flow to the kidney. You need a mean blood pressure of 60. Everybody needs to know that number to maintain kidney blood flow. When your blood pressure starts to drop below 60 for a mean, or say 100 for a systolic, then what starts to happen is the body starts to shift blood away from the kidney and it shifts it to the brain, the heart, and the lungs. Okay? Okay, so again, some of our concerns, sorry, I keep having to pause this. Aspiration, because of not being fasted, also the pressure of the uterus on the stomach. And another big concern I have for these guys is the uterus pushing on the diaphragm. So I may breathe for them a lot more often, once a minute. It kind of depends. I use my CO2 and my oxygen to see how much I have to breathe. And the pressure, the problem is, think about this. The vena cava is coming through the abdomen back to the heart. the uterus is pushing sometimes on the vena cava. So sometimes the heart is working harder to try and suck blood back to it. So one tip, I never know if you guys will remember this stuff, but I feel like I want to fill you with so much knowledge that I know over the years, is when I prep a dog for a C-section, I never lay them flat on their back because the weight of the uterus sits on the blood vessels. So normally I tip them from one side and then I tip them to the other. So I never lay them flat until the surgeon is just ready to come in and start cutting. Because I have seen differences in blood pressure from the time I have them on their side to I shift them. Okay, so you want to keep them on one side or the other and make sure that they get that adequate blood flow. Now, physiologic anemia, due to the fetuses consuming the blood, or not consuming the blood, but taking some of the blood supply, if the mother is in poor condition, she may not be replacing those blood cells at a normal rate. So you definitely want to get a PCB before you start. You got to make sure she's got good blood pressure. They don't need much drugs. To be honest, a lot of times emergency C-sections come in very depressed and in a compromised state, and they don't need a lot of anesthesia. So you can always give more. Keep hearing me say that. And you have to also, now hemorrhage, when you go into for a C-section, the tissues are very friable because everything is kind of stretched to the max, and you can get little tearing of blood vessels. And sometimes there is some bleeding is normal, but you gotta, communicate with your surgeon. If I'm seeing a bunch of bloody sponges going in the trash, I'm kind of getting concerned. And again, they have an increased risk to shock. So you want to watch them extremely closely. Now, as far as protocols, epidurals are helpful. If you can give a morphine epidural and then just give them some midazolam. The problem is it takes time to give an epidural. So if this is an emergency C-section, there's not a lot of doctors that are going to want to take the time to do an epidural. Now, if this is a very healthy, purebred French bulldog that comes in good condition, you might see an epidural done, but I'll tell you, I was at Purdue. We did epidurals all the time, but very rarely were we doing epidurals for C-sections. Most of the time, the doctor's like, get them down, get them in the OR, get the puppies out, wake them up. So I will say that, is an issue. Watch the blood pressure, giving fluids. Now, I will tell you, most of us would prefer to use an injectable and then very low ISO. I never have used an inhalant induction for a C-section because when you use an inhalant for induction, you have to use a very high inhalant. The mother's going to get very depressed. She's going to get very low blood pressure, and the puppies, excuse me, are going to come out very respiratory depressed. So I'd rather give the mother a drug that I love to use, that I got to use a couple times when I was at VCA. I helped out with some C-sections, was Alfaxin. I would just give the mother Alfaxin, and we gave her buprenorphine pre-med. Alfaxin I would give her as she would start to get light. Instead of turning up my ISO, I would give her a little bit of Alfaxin, and I kept my ISO at like 0.75 to 1%. Now, she wasn't in the greatest shape, but as soon as the last pup came out, I turned her up to like 2.5% or 2 on ISO, gave her some more buprenorphine, and that worked really well. Puppies came out great. Mother had good blood pressure. So if you can give them oxygen ahead of time, it's helpful. Propofol is going to be the agent of choice. Ketamine, Valium is only maybe if you didn't have propofol or Alfaxin, but ketamine can really depress the puppies because ketamine is going to go through more metabolism than propofol would. So I would say ketamine, Valium would be very low on my list. Propofol or an Alfaxin would be pretty high. And we like to give them opioids. The main reason is if we get into trouble with the mother or the puppies, it's reversible. She needs an opioid. You just cut open her uterus. So some people are like, oh, I don't want to give her too many drugs. Well, again, if the puppies come out, we can reverse them with Narcan. And again, we usually use stuff like butorphanol or buprenorphine, that doesn't have as much depressant effects as like morphine or hydro. But you can, I mean, I would have no problem giving morphine, hydro, butorphanol, buprenorphine. Fentanyl is cautious, you know, because that's a pretty potent respiratory depressant, but those are all good choices. So we worry, I've talked a little bit about, we worry about low oxygen, high CO2, low blood pressure, acid base imbalance, because again, fluid balance in these guys and the puppies, you know, kind of sucking up calcium, electrolytes, that's your sodium, potassium, chloride, calcium are your electrolytes, and sodium that we look at. And we worry about cardiac arrhythmias due to the, you know, due to the fact that we've got pressure on the heart, we've got pressure on the vessels, poor oxygenation. Now there's a note under here, it says if time permits, give them a pre-med. We don't usually use an anticholinergic, but it says you want quick intubation. Because they're a high vomiting risk, you know, the longer it takes you to get them intubated and secure an airway, the higher they have a risk of aspiration. So that's another pro for propofol or alfaxant. Those two, you can get very quick intubation. Those would be my top two if I need to get a patient intubated quickly. So normally, and there's a lot of extra notes under here that you want to look at. But if we get the puppies and kittens out, how you take care of them, normally we set up a little station. So I'm usually involved with the mother in anesthesia, so everyone else gets to be fun with the puppies. But normally we'll set up a little, like a heating pad, towels, and we'll have oxygen so that you can put a face mask. We'll get like a little face mask, or you can put just the oxygen in front of their nose. If you have to intubate them, you can use an 18-gauge IV catheter. You're not getting an endotracheal tube. These are newborns. So you would have to actually use an IV catheter, take the stylet out, obviously, and you could pass that in. But a lot of people, we just take one of those bulb syringes they use for babies. You can put that back there and suck out any fluid. I rub them very vigorously. I know some people say not to shake them or swing them between the legs, but that's how I was taught. So the bulb syringe, clean their mouth, clean their nose. Don't be like, oh, you're so cute. Rub them, rub them, rub them, rub them, rub them, rub them. Be aggressive. We're trying to stimulate them. And then if we're still not getting crying, breathing, I love when I can hear the crying. I'm like, there's the crying. They're alive. Then you can use reversal agents like naloxone. We don't usually use dexdomitor in C-sections, I will tell you. That's a little potent and a little heavy for what we want to do. And then doxapram is a respiratory stimulant. I told you guys, the only time I use doxapram, and I've not used it a lot because its use is controversial, my anesthesiologist didn't like it. You would give it to stimulate breathing in C-section puppies, and potentially give some atropine if their heart's not beating. So you got to try really hard to get them stimulated. You can do little cardiac massage on their, chest, kind of go peep, 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 try to get their heart beating, give them oxygen, try to reverse any reversible agents. And then if the puppies, now right now mom's still having surgery, we usually keep them in a heated box. Once mom is recovered, typically, I would say normally about an hour to an hour and a half after she recovers, we try to put the pups with her. And you got to watch them close, because if she is too groggy, you don't want her laying on a pup, sitting on a pup, stepping on a pup. If she's kind of like and flops over on top of the puppies, they can't do anything about it. So I would usually say, within about 45 minutes to an hour, she should be kind of putting her head up, looking around. And the nice thing is if we give her morphine, it's not going to be, by the time it gets to the milk, it's not going to be enough morphine that it's going to affect the puppy. So you don't really have to worry about any of the post-op meds in the mother. Now, you don't want the mother too sleepy where she can't take care of her puppies, because really, in an hour to an hour and a half, we got to get her nursing them. They need that colostrum. So you definitely want to try to get them going fairly soon. Now, the other thing that I should say, sorry, I'm trying to fix this. What is this? Okay. Trauma patients. And trauma is extremely broad. Could be hit by car. I mean, that's the number one reason I think of is hit by car, run over, stuck in a recliner, hit by garage door, dog fight. So is obviously they are at an increased risk. And one thing that we worry about is, and this really depends on the trauma, but these guys can have pneumothorax where their lung ruptured and air leaked out, or sometimes a rib gets broken and a rib punctures the lung. Now, a pulmonary contusion is like a bruise on the lung. So when a dog gets smacked by a car, everything in the chest kind of gets shook around. And so sometimes when the lungs bump up against the chest, they get bruising. Well, what happens is bruised lung typically has blood in it, and the blood fills the alveoli, and then the alveoli can't hold oxygen. So if you have a bunch of bruised lungs, they do not circulate, the perfusion isn't adequate, and you can get alveoli that are filled with a little bit of blood or extra fluid that aren't filling with oxygen. The other thing we worry about is bleeding into the chest and or diaphragmatic hernia. If an animal, remember the diaphragm splits the thorax from the abdomen. If the animal gets run over, a lot of times the diaphragm will tear. Abdominal contents can actually move into the thorax, and sometimes even lungs can go into the abdomen. It's like they switch. And so these guys are going to have major problems ventilating and circulating. Those are my big concerns in trauma. Now, this V with the T, if you remember, is tidal volume, which is the amount of air moved in one breath. Anything that affects the lungs' ability to expand automatically decreases tidal volume. If you have a bunch of intestines in your thorax, you are not going to be able to adequately expand your chest. Therefore, you are going to have a decreased tidal volume. Okay, that's just space, physics, and physiology. So oxygenation in these guys is going to be key. Can they breathe deeply enough to maintain their oxygen? Also, bruising in the lungs, pneumothorax usually patients will have a higher CO2 because they're not able to adequately expel or get rid of CO2. And the more CO2 you have, throws off your acid base, which is your pH, right? And it can predispose them to cardiac arrhythmias. The other thing we worry about is low blood pressure from, well, actually shock, because if the patient is shocky, now if they've lost blood, they're going to be in shock, which is called hypovolemic shock because they don't have enough volume. Now, there is something called fluid sequestration anemia. If an animal gets hit by a car and all of the blood, like maybe our blood vessel ruptured and the blood is in the thorax, the blood is supposed to be in the blood vessel. It's sequestered or being kept in the thorax. So it is an anemia because when you draw blood on that patient, it's going to show a low PCV. Now, did they bleed out externally? No. The blood is in there, but it's trapped or sequestered in an area where the animal can't get access to that blood. So that's what's called fluid sequestration anemia. It's stuck somewhere where it's not supposed to be. So the problem is that doesn't help us. The blood in the thorax, in fact, it's hurting us because when there's blood in the chest, the lungs can't expand, and we also have to try to resolve the anemia. So the big thing is you have to try to stabilize them before you do anesthesia. So what you have to really do is assess what are the true injuries. Um, and then if you get them in a more stable state, anesthesia is going to go more smooth. Now, let me mention something. And I was on ER one night, hit by car comes in, dog's leg is dangling, all mangled, multiple fractures you could see on the forelimb. And so the doctor's like, and she was a young doctor and had a great relationship with her. But you know, she knew she was new, and she was like, okay, we need to flush these wounds. We got to bandage this. We got to take x-rays. And I was like, I don't like the way his heart sounds. I'm like, it's kind of speeding up, slowing down. It's definitely not a regular heartbeat. And she's like, yeah, okay. So we'll look at that, but go get radiology set up. Go get me drugs. We got to knock him down. And I'm like, but I'm really concerned about his heart rate. And I gave him some sedation. And sure enough, he starts throwing runs of tachycardia and what's called like supraventricular tachycardia. So the heart's just going da 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 da. And she's like, oh my gosh. And so we reversed him. We woke him up from sedation, got him on nasal oxygen, ran an EKG, saw the abnormal heartbeat, did oxygen therapy and pain medication. We just threw a quick wrap on the leg to just kind of like cover it so the bone wasn't exposed. And in 24 hours, the dog's arrhythmia resolved. It had decent blood pressure and went to surgery for the leg. An animal will not die from a broken leg, as bad as it looks. And some look pretty awful. A broken leg, unless an artery is pumping into the air, that broken leg is not going to kill that patient. But if you prematurely anesthetize that dog and miss a pneumothorax or miss an arrhythmia, that can kill the patient. So you don't, as bad as traumas look, I mean, there are traumas. If the dog has a ruptured spleen, is bleeding into its abdomen, you have to go to surgery because you have to take out the spleen and stop the bleeding. So I will say there are levels of trauma that if you have a diaphragmatic hernia and it's acute, you have to get that dog into surgery. So you don't always have time to completely stabilize them. But if you have the opportunity to give them oxygen, give them pain meds, give them fluids before surgery, you're going to be in a much better situation. And you want to watch for developing dyspnea or arrhythmias, because I will tell you, some animals come in with that. They release epinephrine, their fight and flight, and adrenaline kicks in, and they walk through the door looking pretty darn good. And then all of a sudden, they start in an hour or two having breathing difficulty, have arrhythmias, have low blood pressure. Because remember, I've told you in anatomy, the spleen can contract and pump out a bunch of red blood cells. And so if an animal was bleeding out, they could walk in your door because that kind of acted like a Band-Aid, and then all of a sudden an hour later they crash. And I've seen it happen. I've told that story too. So you definitely want to try to also get a thoracic x-ray. But again, you can kill an animal taking an x-ray. If they're in respiratory distress, you never want to force them to lay down. If an animal is, I mean, I've seen animals gasping for air, and I've seen cats try to attack us because they can't breathe and they get panicky. It's not a mean cat. It's a cat that's panicked that they cannot breathe, which breaks my heart. When you see an animal that's gasping and panicking and flailing, you got to get them oxygen and you got to help them breathe. And those animals will act out because they're panicked, they cannot breathe. So you got to get oxygen, you got to calm the patient. If you can get a quick x-ray and then run them into oxygen, like sometimes we'll literally do a lateral, take them to oxygen, wait an hour. Go take a VD, go put them in oxygen, wait an hour. Then come back and do your right. You see what I'm saying? Like, you can do radiographs in stages, but no x-ray is worth a dead patient. And I mean this because I've seen it, and I've seen people wrestling a dog, and I've seen people kill a patient trying to take an x-ray. So you don't want to do it if they're panicking. Okay, just be very, very careful. So what we can do to stabilize the patient is, you know, if we suspect that there's trauma to the chest. You can get collapsed lungs, punctured lungs, pneumothorax. What you have to do when an animal has pneumothorax, there's a thing called thoracocentesis, where you put a needle in the chest and you have to suck out the air. And what that does, remember, the chest is supposed to be negative pressure. Your lungs are able to expand. So any fluid that you can remove from the chest, any oxygen, and then you want to try to give them nasal oxygen. And let me show you the picture. So here's a patient that has nasal cannulas. So these are actually orange rubber catheters. We use these for feeding tubes. We use these for urinary catheters. But what they're doing, they put that in the nasal meatus. So it just goes from the nose to about the canthus. This isn't like shoved down their trachea. This is just giving them what's called nasal oxygen. And this dog has two. So all you do is you put it in the nose. We put a little stitch or staple there, a stitch or staple. And then this dog has two oxygen hoses going to it. He's obviously pretty depressed, looks very painful. Now this is a dog that what they did, now if you don't have or no one knows how to do that, and techs can do this. I've placed plenty of nasal oxygen tubes. This doesn't have to be a veterinarian procedure. Technicians can place nasal oxygen, and I can, and that's a suture you can do. We cannot suture after surgery, but I've sutured in feeding tubes, and I've sutured in like EKG leads. So there are some suturing techniques that technicians can actually do. What they did for this dog is they put an e-collar, and then they put saran wrap over the end, and then they piped in and taped this oxygen tubing. So this acts like a little oxygen hood. Now you do have to put a hole somewhere so that because they're going to exhale. We don't want to make a CO2 tent. So normally we poke a little hole somewhere so that the CO2. Now this is a little bit wasteful, but if you can't do that, you can do that. And then here is the procedure to do a chest tap. Like again, this is normally done by the doctor, is we basically, the best way to do this is also we put them in sternal. And I usually pull their front legs forward because you have to get to about between the 7th and 9th rib. And most dogs, where their elbow is about the 5th, 7th rib. So normally I lay them forward and I pull either one or both legs. And then the doctor goes between the 7th and 9th rib. You just get into the pleura. And you have to clip and prep this like a surgery site because you're going into the chest cavity. So we do a clip like a square. I can try and find a chest tap video to show you guys. You may have watched one in another class. But we also have to use a very, I think this is funny, a 1 and a 1.5 inch catheter. The doctor I used to work for, my criticalist, is like probably my favorite doctor I've worked for. He used a 14 gauge 5-inch catheter because if you think about the thickness of the chest wall, you have skin, you have fat, you have muscle, you have 2 layers of muscle, and then you have the chest cavity. This is 1.5 inches, okay? You're gonna need probably at minimum a 2 to a 3-inch catheter, and like he said, he used a 5-inch catheter. And a stopcock. Now it's too hard to explain. I'd rather find a video for you to watch. Now, cardiac arrhythmias can persist for days. It can be 12 hours. It can be 72 hours. Normally, when a trauma comes in, one of the first things we do is we try to put them on an EKG and get a printout, see what their ECG is doing. Now, there's medications like lidocaine, atenolol, propranolol. There's medications that can treat different types of arrhythmias, and it just depends on the arrhythmia. And not all arrhythmias are treated with meds. Sometimes oxygenation, like when animals have a VPC, which is premature ventricular, or PVC, VPC, people call them both. But anyway, a lot of times, those are treated by giving the animal oxygen. Now, if they're severe, they typically use lidocaine, but oxygenation can improve a VPC. When you definitely want to listen to these guys and and I will tell you, some of our traumas, we will put them on an ECG continuously. Like we'll leave them hooked up and put the ECG right outside their cage. Sometimes you'll just spot check them, like do an EKG every 4 hours. It kind of depends on the doctor. It depends on the setup of your practice. But in the ICU and the ER, we can put on, we sew in wire where the ECG leads and they clip on so they don't clip on the skin. And that way you can do a 24-hour EKG. And then the big thing we worry about with shock is hypotension, and that's literally what shock is, usually low blood pressure. And because shock causes low blood pressure gives you low tissue perfusion. And how we monitor this is you can use a Doppler to check blood pressure, and a oscilloscope is like the cuff. But I will tell you, the best method is the Doppler is the most accurate. You might feel digital palpation as you feeling a pulse, but most of the time a doctor is going to want an actual number. So here is the consequence that I want everybody to understand. When you have low blood pressure, you don't have tissue perfusion. When you don't get oxygen to the tissues, you get tissue hypoxia or anoxia, which means no oxygen. Then it causes something called anaerobic glycolysis. That is breaking down of the stored glycogen in the tissues without using oxygen. So that's why it's called anaerobic glycolysis. Glycogen, lysis, breakdown. Then what happens, and I said this way back in anatomy, I just lectured to my new students about this. When you get into what's called anaerobic metabolism, the byproduct of that is lactic acid. A buildup of lactic acid in the body causes an acid-base imbalance, throws off your pH and your electrolytes. That affects how your cells function. Your cells die, patient gets sick. Do you see this as like a cascade of effects that's going to happen? So what we got to do is we got to get them out of shock or treat shock very aggressively and very rapidly to prevent that situation from getting worse. So what do? We're going to give fluids, typically start with a crystalloid, which is like LRS, plasmolite. And sometimes you have to do bolus, like if they have a really crappy blood pressure, super tachycardic, we will do very fast fluids. We're not talking about drip. We're going to be pushing them in. Now crystalloids, and hopefully you remember this from fluid therapy, they don't stay in the vessel maybe a couple hours. So what's going to happen is they're going to escape into the tissue. So if you give too much fluids, you can run into edema or fluid overload. Cats that are shocky are particularly sensitive. When cats come in with like a trauma, we give them fluids, but we don't push them quite as much as we do with dogs, because they found that cats are more sensitive to that fluid overload. And what happens when you overload a cat? It goes to the lungs first. So you'll drown a cat. You'll basically fill their lungs with fluid, and then you've got a respiratory problem on top of a shock problem. Okay, so you got to be careful in cats. We're going to watch their heart rate, blood pressure, color. That's how we monitor, are we treating shock? Are we treating hypotension adequately? The other thing is, if we have a severe shock, a lot of times we're going to give a colloid with our crystalloid together. Now remember, I told you this was like week 1 or 2. I talked a little bit about fluids. You never give a colloid by itself, right? Unless you're giving plasma. But when you're using like Vetastarch or Hetastarch, you're usually giving it with LRS, with plasmolite, because colloids by themselves will pull fluid to them, can actually dehydrate the patient. But what you're trying to do, if you cannot maintain blood pressure with just LRS alone, Vetastarch is going to hold on to that plasmolite or that LRS, and it's going to keep it in the blood vessel. The longer fluid is in the blood vessel, it doesn't fill up the tissues, and it helps increase blood pressure. When you can boost vascular volume, you put more pressure in a vessel. So it's going to increase osmotic pressure. Osmosis is when fluid is drawn to it. So by putting a bigger molecule in the vessel, you draw fluid and you keep it in. So it's always given in a smaller, I've never squeezed a giant bag of head starch. You usually calculate an amount and you give that amount. Your fluids your LRS is usually going higher than your colloid. So this is going to you're going to watch their heart rate and blood pressure because you don't want to make it go too high. You're going to watch their color, and if they're awake, look for the signs of fluid overload. You've had this lecture, the chemosis, crackles, edema, nasal discharge, excessive ocular discharge. So those are all signs that you're potentially overloading the patient. So you have to be very, very, and here's some more: coughing, vomiting, restlessness. Okay, so those are all signs that, like, hey, maybe I'm giving too much here. Now, diaphragmatic hernia there's very different forms of diaphragmatic hernias. I will tell you, trauma is probably the biggest one: hit by car, run over, or sometimes dogs have what are called, or cats, is a congenital diaphragmatic hernia. What happened is that maybe as a puppy, or the diaphragm didn't form properly, and then all of a sudden they have problems with their diaphragm, and it doesn't show up till later in life. But either way, that is, a lot of times they're going to present in respiratory distress because usually abdominal contents go into the chest and it prevents the lungs from expanding. So they have trouble breathing. You want to always, and usually what we end up doing is, I never want to lay a patient with their head down, because the problem is the abdominal, if this is the head, abdominal contents are in the chest. I'll often tip them to help those. I want to relieve pressure on the lungs. I don't want to make it worse. I want to try to improve it. So if I can tip, then some of those contents are off of the lungs, and hopefully the patient can breathe better. Usually these guys are going to be, I will tell you, they are normally, well, when you open an abdomen and a diaphragm is open, you automatically have an open chest. Those dogs are going to have to be on continuous ventilation. They cannot breathe on their own. When you open the abdomen and there's a hole in the diaphragm, all the atmospheric air rushes into the chest, and the lungs, the dog will look like it's trying to breathe. They cannot expand their lungs. Until the diaphragm is sealed and the doctor sucks the air off the chest, you have to ventilate 100% for the patient. So 100% ventilation in a diaphragmatic hernia, okay? And then you're going to watch them very close for like the bluish membrane cyanosis. Watch their blood pressure, because often, because everything's been kind of twisted around, like everything kind of flipped, you can have issues with blood flow in the abdomen. You can have issues with blood flow in the chest. You want to make sure they have a good SpO2. And like I said, you have to ventilate them well, 100% controlled. So it's CPPV, not IPPV. And then watch them very close in recovery, because these guys, I will tell you, I try not to get over detailed, but when the lungs have been compressed, so if the dog, and it depends, did this happen, was he hit by car 10 minutes ago, or was it yesterday? Was it a farm dog that we didn't find for 3 days and now he came back and he looks like crap? But when the lungs have been compressed and not ventilating properly, when you reinflate them, they get this post-inflation edema. And sometimes, because the lungs were overexpanded after they've been compressed, they can fill with fluid. And you don't usually see that until they're in recovery. So all my diaphragmatic hernias, I didn't go crazy like squeezing the bag, like, in fact, normally I kind of underventilated them. I tried to not overinflate, because We were worried about this post-inflation edema. And so when they're in recovery, you have to watch their respiratory effort, look for coughing, look for cyanosis very, very, very closely. Okay, let me, I'm going to end because that's all kind of like the anesthetic problems and challenges. And the next lecture I'm going to record tomorrow is going to be the one that focuses on CPR and resuscitation. So I will stop here.